This is Phyllis Dumont welcoming you to the section on disease-modifying anti-rheumatic medications and immune modulators. This is a class of drugs that are usually not prescribed by primary care providers, but their use has proliferated and their number has proliferated, and primary care providers are responsible for monitoring patients who have been placed on these medications either by most often by their rheumatologist and sometimes by gastroenterologist, Okay, drug overview. We can think of these drugs as being divided into conventional disease-modifying anti-rheumatic drugs, or DMARDs, the antimalarials, the sulfonamides, and the antineoplastics, and the immune modulator drugs, which include cytokine blockers, specifically tumor necrosis factor alpha inhibitors. Another cytokine blocker is an IL-1 receptor antagonist, and T-cell modulators. Corticosteroids can be looked at as also being disease-modifying anti-rheumatic agents. However, these drugs have so many side effects that their use is rather limited. The indications for these medications include rheumatoid arthritis, psoriatic arthritis, and Crohn's disease, as well as ulcerative colitis in the GI conditions for which these are frequently prescribed. All patients with suspected rheumatoid arthritis need to be referred to rheumatology for initiation of medication. As their name implies, the disease-modifying agents have the potential to prevent the destruction of the joint that can occur with severe rheumatoid arthritis. So the primary care role becomes working with specialists in monitoring the course of this disease and their progress on the medication. So, conventional disease-modifying anti-rheumatic drugs, or DMARDs, they have anti-inflammatory effects, and they slow the progression of and preserve joint function. Their exact mechanism is in many cases unknown. Hydroxychloroquine has anti-inflammatory properties. The brand name for it is Plaquenil, and we'll summarize that on another slide. And the sulfonamides, their mechanism is unknown. They have both antibacterial and anti-inflammatory actions, and they are, the example that we're going to use for those are drugs that are used in the treatment of Crohn's disease and ulcerative colitis. Chloroquine, or Plaquenil, in rheumatoid arthritis, it is known to suppress T lymphocytes and to decrease leukocyte chemotaxis. It inhibits DNA and RNA synthesis, and it also traps free radicals, which are known to be destructive to many cells. It inhibits phospholipase A2. And this leads to an improvement of symptoms of rheumatoid arthritis. There's no evidence of extensive protection with this drug against bony damage. It doesn't have any use in juvenile rheumatoid arthritis, so it's restricted to use in adults. Contraindications to its use are either the presence of retinal or visual field changes and or their development during treatment. It takes several weeks to see any effects from this medication and 3 to 6 months to obtain a maximal response. And the side effects include ocular toxicity at higher doses, and so regular visits to the ophthalmologist are in order. Sulfasalazine is an aminosalicylate. Its indication is Crohn's disease and ulcerative colitis, again managed by GI, not rheumatology. The mechanism of action is a topical effect. It inhibits the production of inflammatory mediators from both the cyclooxygenase pathway and the lipooxygenase pathway. Sulfasalazine was developed to be able to deliver both antibacterial and anti-inflammatory therapy into the colonic mucosa. There are many formulations in this class of drugs, all designed to prevent the breakdown of the drug before it reaches the terminal colon, where some of the disease may be active. But we're not going to discuss those in any kind of detail. Adverse effects include headache, nausea, vomiting, and anorexia. Rash and fever, possibility. Hepatitis, a chemical hepatitis is a possibility. Agranulocytosis, pancreatitis, hypersensitivity, pneumonitis, and there can be reversible sperm abnormalities. You think of it as a anti-cancer medication. Its mode of action in the lower doses used in its treatment as a DMARD are anti-inflammatory and immunosuppressive properties. It impairs DNA synthesis, and recall that there's a proliferative process going on within the joint in rheumatoid arthritis. And so we want to stop that. It exhibits inhibitory effects on cytokines, especially interleukin 1. And that anti-proliferative effect on the synovial cells is joint preserving. The immune modulators mode of action, these are agents that regulate the extent and duration of the immune response, and these drugs target cytokines and T cells. Specifically, they target tumor necrosis factor, interleukin 1, and T cells. The mode of action of this class of drugs is several different approaches. Cytokine blockers, the tumor necrosis factors, inhibitors bind to tumor necrosis factor and inhibit interaction with the cell surface receptors. The cytokine blockers block IL-1 competitively, inhibiting binding to the receptor. The T-cell modulators that inhibit T cells by binding to CD80 and CD86, they block interaction with CD28. And luflunomide, or Rava, blocks the synthesis of pyrimidine, which is required for proliferation of T cells. Now, corticosteroids are included in this, although they are an older drug, but they have anti-inflammatory and immunosuppressive effects. They inhibit the production of interleukins, which decreases the immune response through diminished activity of T cells. They affect types and numbers of leukocytes and monocytes in the serum. And of course, as you recall, they affect carbohydrate, protein, and lipid metabolism and increase hepatic gluconeogenesis. So the DMARDs and immune modulators generally are prescribed by the rheumatologist. So the NP role is to monitor for response to medication and adverse reactions. We can also suggest non-pharmacological measures for comfort and control of the illness, and the importance of early aggressive treatment with DMARDs as first line, so that our patients get referred early enough to avoid the irreversible joint damage. And patients may be on combination therapies, which we may have a role in monitoring. Embra was really the first tumor necrosis factor blocker approved for the treatment of rheumatoid arthritis in 1998. There are now about 11 currently approved. Each has demonstrated high efficacy, and each is associated with uncommon but serious adverse effects. So Entanercept can be used in monotherapy or in combination with methotrexate for moderately to severe active rheumatoid arthritis. It improves signs and symptoms of the disease, and it inhibits progression of structural damage. In juvenile rheumatoid arthritis, patients who have a polyarticular course, it can be used, and it's also used in psoriatic arthritis. When we think about why people are prescribed the tumor necrosis factor blockers, about a third of them are prescribed for the treatment of rheumatoid arthritis, close to another third are prescribed for the treatment of psoriasis, about 18% are prescribed for the treatment of ulcerative colitis, and about 18% for the treatment of Crohn's disease. Infliximab, or Remicade, is a chimeric monoclonal antibody to tumor necrosis factor alpha. A chimeric monoclonal antibody is a genetically engineered antibody that contains both non-human and human genetic material. The human genetic material is attached to the molecule in order to help limit some of the immunogenicity of the substance from the body, so that the body won't react quite as violently to a foreign protein. It can be used in combination with methotrexate for moderately to severe active RA. It improves signs and symptoms, it inhibits progression of damage, and it leads to an improvement in physical function. In Crohn's disease, it's used to treat active disease, and especially Crohn's disease where the patient is forming fistulas. This medication is indicated for a trial. Adalimumab is a monoclonal antibody to TNF alpha factor. It is a sequenced human-derived, but studies still demonstrate quite a bit of immunogenicity. It doesn't have the chimeric component. Pivotal trials assess the safety and efficacy of using it in monotherapy or of combining it with methotrexate, and it has become an add-on to the standard of care. So it can be used in monotherapy or combination with methotrexate or other DMARDs for rheumatoid arthritis. It improves the signs and symptoms and it inhibits the progression of structural damage. Safety concerns. There are several recognized adverse events that are relatively common and need to be monitored for. When I say relatively common, they're not rare. The TB risk is significant, in part because these agents interfere with T-cell immunity, which helps to fight TB and lowers the immunity in general. Another side effect of lowering your immunity in general is the possibility that there will be an increase in certain cancers, specifically lymphoma and other malignancies that have occurred with all of the agents. Liver injury has occurred with infliximab and Taracept, and congestive heart failure has occurred through mechanisms that we don't really understand. TB was seen in the clinical trials with infliximab. The cases of TB, some fatal and with very unusual presentations, meaning perhaps non-pulmonary TB, were observed in post-marketing reports. And the reporting rate was several-fold higher than the incidence in the U.S. population, so it was a significant change over baseline. And TB was seen in patients who would not otherwise be considered at risk. So there is a boxed warning requiring screening and prophylaxis recommended for all patients on these medications. And Taracept, TB is a little less common in the post-marketing experience. The reporting rate was similar to the U.S. incidence. But most U.S. patients who have developed TB on etanercept have been otherwise at high risk rather than being someone that you wouldn't otherwise be concerned of having TB. So this label is a bold warning. So primary care concerns can be summarized by saying we need to be vigilant for the development of TB. We need to be vigilant for the development of malignancies and lymphoma. We also need to watch for liver enzyme elevations and hepatic adverse effects and congestive heart failure in our patients who are on these medications. Endocrinologists should follow patients closely. We should watch for indicators of reduced disease activity. So we should see a drop in the SED rate and in the C-reactive protein levels because these patients shouldn't stay on these medications if they're not improving. Adverse effects we want to watch with CBC with differential, looking for blood dyscrasias. We need to do a CMP and a UA on hydrochloroquine or Plaquenil. Patients need blood counts, they need to see ophthalmology, and we should check muscle strength and knee ankle reflexes on these patients. Adverse effects for sulfasalazine. We should check a CBC with differential, liver function studies, UA, and renal function. Patients on methotrexate should have a CBC, albumin, creatinine, liver function studies, and baseline alkaline phosphatase, chest x-ray, hepatitis B and C in high-risk patients. Monitoring the adverse effects on immune modulators, TB test before initiation of therapy, risk factors for infection, signs and symptoms of infection, CBC and liver function tests. Patient variables in pregnancy, Plaquenil is considered category C. In lactation, it's thought to be probably okay. Sulfasalazine is category B in pregnancy, and there's little known about its safety in lactation. Methotrexate is category X, and it's unsafe in lactation. The TNF inhibitors are category B. There are no adequate studies, and there's not much information on lactation. Pregnancy and lactation, the IL inhibitors are category B. The safety is unknown in lactation. T-cell modulators, abatacept is category C. Lactation, safety unknown. Leflunomide is category X, and it's unsafe in lactation.